Thank you for joining us. We're going to explore what is an ACO. An ACO is a legal entity that is working with a group of providers in order to take responsibility for the outcomes for a population of patients. And the outcomes relate to quality of care, health outcomes for the group, as well as total cost of care or spending. ACOs generally have a governance structure along with a number of services that are managed by the organization. They have legal services, they have IT infrastructure, and as we'll see more in a few minutes, they have other capabilities that they develop to help manage the care of their populations. As I mentioned, ACOs work with a network of providers. In many cases, those providers are not affiliated with each other. They are often independent providers who have agreed to work together under the ACO structure. In some instances, an ACO may be formed with an integrated delivery system where two or more of the components of the system are under the same governance structure, but that is not a requirement of the ACO. And in many cases, even when an integrated delivery system is part of an ACO, it has to work with providers that are independent as part of the ACO to offer the full suite of services. So ACOs work with their network providers in a number of ways. One of the most important is that they develop a set of clinical protocols that all of the providers who are working with the ACO agree to deploy. And the clinical protocols are really important because this is where you help eliminate some of the variation in quality and health outcomes that impact your cost, that impact the health outcomes for the beneficiaries. So the idea here is to identify what are the protocols that will lead to the best results and how do we standardize those across all of the providers participating in the ACO. In order to help providers do this, the ACO provides data analytics. These analytics are used to stratify patients by risk, so to, in other words, identify those individuals who need more attention from the providers or who are at risk for certain complications or certain adverse events. Those analytics also help identify variation that's occurring in real time. So if you have a particular provider or a particular patient that is varying from the expected course, that you can identify them and intervene. And then ACOs often have the ability to share in savings with the providers who are in the network. So as we'll talk about more in a minute, ACOs generally do not pay providers for the services that they provide, but they may, if the ACO is successful in the model and is sharing in savings with the payer, may share some of those savings with the various providers. ACOs also must have robust care management infrastructure, and this is really critical to ensuring that the beneficiaries that are assigned to them, that they are accessing care at the right time, that they aren't, they're reducing inappropriate utilization, that they're intervening in the right moments. For instance, making sure that they're up to date on all their preventive services, or that patients know where to go when they may be experiencing an urgent medical need, but not necessarily an emergent medical need. So the care management infrastructure is very critical. And ACOs can build that infrastructure in a number of ways. They can have it in-house. So for instance, an ACO may itself contract or employ care managers or utilization managers to help with the care management of the population. Or they may contract with some of the providers. For instance, their primary care practices serving as primary care medical homes to take the responsibility for that care management function. Now, this is one instance where the ACO may pay a provider for the services that they provide. Again, if they are contracting with them to deliver or to provide the care management services. So with respect to the payers, and of course, CMS and Medicare are probably the best known or most known to be affiliated with ACOs, real leaders here. But numerous other payers are working with ACOs, so our commercial payers and Medicaid managed care plans. So the relationship between ACOs and payers is generally not one of payment. So for instance, the payer is not providing a capitated payment to the ACO. Instead, they're setting performance standards and a spending target for a certain population. And then if those two things are met, the ACO may be eligible to share in savings. And this is really when money is sort of exchanged between the payer and the ACO. It can go in one direction, which again is shared savings. So if the targets are met and they are above a certain threshold, then the payer keeps some of the money and the ACO receives some of the savings. In some instances, for some ACOs, there are also shared losses, which are if the performance standards and spending target are not met, the ACO may be responsible for repaying to the payer a portion of the losses. Similarly, the providers maintain a direct payment relationship with the payers. So, for instance, the Medicare program would continue to pay the hospitals and the physicians and the home health agencies and others their traditional or standard payment. So in many cases, that would be a fee-for-service payment that those providers receive. And again, this is one area where the ACOs and managed care, for instance, are different. The ACO, again, does not receive a capitated payment and then makes payment for services to those providers. Those providers retain a payment contract and relationship directly with the payer. One other thing to note that is different between ACOs and managed care organizations are the patient populations that ACOs are responsible for. So ACOs are assigned a group of patients to manage. And what that means is these are not enrollees. These individuals are not necessarily bound to get all of their care from the ACO. But basically what the payers does is they look at the historic utilization of a group of individuals, a group of beneficiaries, and says, you know, the providers that are part of this ACO were really the main providers who are providing services to this group of individuals, let's say in the last year. Therefore, it makes sense that this beneficiary be assigned to this ACO for care management because it's likely that the beneficiary will continue to see the same providers in the next year. So they're assigned a group of beneficiaries, and this is the group of beneficiaries that the payer uses to set the spending target and also the performance standards. However, again, these beneficiaries aren't required to stay with the ACO. If at any point in time they go to see a provider who's outside of the ACO, say it's whether it's a physician or a hospital or any other type of provider, the ACO cannot prohibit that. The ACO is still responsible for hitting that spending target. So, of course, they have a very strong incentive to try to motivate those individuals to stay within their network. And they may do that in a number of ways, not least of which their desire to contract with providers who are known to be of high quality and are patient preferred. So a little bit on the different variations of ACO programs, and here I am going to focus on the Medicare ACO programs, even though, again, there are variations that occur in the commercial and in the Medicaid markets. So the first is the basic ACO program. It's the Medicare Shared Savings Program. This is a permanent program under Medicare for fee-for-service beneficiaries. There are several different models of ACOs under the Medicare Shared Savings Program. There's a model where providers can come together as an ACO and only be eligible for shared savings initially. There's also a model which has both upside and downside risk. So that means that not only is the ACO eligible for an incentive payment, but they could also be eligible for losses. And again, this is the permanent program under the Medicare program. Providers do need to apply and be approved by CMS to participate, and then they enter into multi-year contracts. CMS also offers several opportunities for providers to get some upfront investment to help them build their ACO capabilities. So this is the ACO investment model and the advanced payment ACO model. So as I mentioned before, generally the only money that sort of exchanges between the payer and the ACO is for when there's a situation of either shared savings or shared losses. Generally in ACO programs, the payer does not provide any upfront funding to providers to establish the ACO. However, CMS, in their desire to build this model out, recognize that not all providers and not all communities have the care management infrastructure in place. So these two models provide some upfront money that providers can use to build that infrastructure. In these models, though, the idea here is that any money that is provided upfront to the providers would be repaid essentially through a decrease in their shared savings on the back end. If the provider is does not earn shared savings on the back end, they could be responsible for paying back some or all of that money to CMS. CMS also offers some specialty ACO programs like the Comprehensive ESRD Care Initiative. And this is the first. There will likely be others of programs that are really, again, called specialty ACOs, where you're looking at a population that has very specific healthcare needs, and so therefore can be much more tailored to those populations. So for instance, the provider network may look very different than a provider network for an ACO that is caring for sort of your standard Medicare population. And then finally, there are the Pioneer ACO model and the Next Generation ACO model. These are much more advanced ACO models for organizations that already have significant experience coordinating care for beneficiaries, perhaps even taking risk for them for some or all of their services. And in the Next Generation ACO, this is one that's operated through the Center for Medicare and Medicaid Innovation, where there are a number of waivers available to providers, and providers can ask CMS for even other waivers that they've thought up, that would allow them the flexibility to test new models of care. And if CMS approves those waivers, and through the demonstration project they prove to be successful at helping achieve the triple aim, this is where CMS can say, or take elements from these models and employ them in the permanent programs, such as the Medicare Shared Savings Program. So this is our summary of what is an ACO 101. We look forward to hearing from you and furthering our understanding of new models of care. Please continue to refer back to the website and let us know how we can help you in better understanding these new models and preparing your organization to participate. Thank you.